Hello and welcome to this episode of the Queen Bee podcast. Today we're joined by Dr Ceri Cashell, a specialist GP focusing on hormones and their impact on women's health. Ceri is passionate about increasing public awareness, enhanced medical education, and ensuring women have access to the information, support, and access to hormone therapy, and access to hormonal therapy where that is the best option for long-term health outcomes. Thanks for joining us here today, Ceri.
Thanks for having me.
So let's start with something controversial, which it doesn't seem it should be controversial because we've had the pill for years. So why is hormone therapy such a taboo topic?
Yeah, that's such a good question. And I think it, like many things, has probably multiple answers. But the simplest answer would be that in the 1990s, approximately 40% of women, certainly in the US, were prescribed hormone replacement therapy, HRT, or what's now called MHT, or others call just hormone therapy. And they were really saying those women were doing quite well in terms of both quality of life and longer term outcomes. So there's quite a lot of studies in the 80s and 90s showing reduced cardiovascular disease in women who were taking HRT. So around about, I think it was 1997, the first ever female director took over the National Institute of Health in the US, which really determines a lot of medical research in the US. And obviously the US is one of the biggest sort of determinants or forces in what happens in research and health in the Western world. So she commissioned a $1 billion study into the effects of HRT on long-term health in women. And in retrospect, very unfortunately, they chose to use two hormones. One, the estrogen is conjugated equine estrogen, which is the estrogen that's made from pregnant mares, so pregnant horses' urine. And to be fair, actually, that's not a bad estrogen, but they used a synthetic progestogen called medroxyprogesterone acetate, which is one that we don't tend to use anymore. So they recruited women who were on average quite a bit beyond menopause, on average aged 63. So the age range, I think, was 52 to 79. They didn't account for smoking or previous cardiovascular disease. They didn't really stratify any risk into that. So they took quite a sort of an atypical group than your typical menopausal group of women. They also weren't allowed to have any symptoms of menopause, which has issues in itself. And so they had an arm of women, the women that still had their uterus, so women who hadn't had a hysterectomy were put on the equine estrogen plus medroxyprogesterone, and women who didn't have a uterus because they'd had a hysterectomy were only put on estrogen. And in about 2002, the researchers, this was a big trial, I can't remember the number of participants, but it's a couple of 100,000 from memory. They would have met every 6 months to discuss the latest findings and, what was happening in each state. And in 2002, they met up and a small subgroup of researchers had sort of independently gone and drawn up some findings that suggested that there was an increased risk of breast cancer in the combination HRT groups, so the women on estrogen, medroxyprogesterone. And they were concerned that this maybe didn't meet significance. So was this something that could have occurred by chance, or was it really down to the use of the HRT? So the other 90 or so researchers demanded to see the data, and what they found was that this increased risk of breast cancer that the small subgroup had found didn't actually meet the sort of statistical tests that would determine if something was a chance occurrence or not, like flipping a coin. But unfortunately, and this was happening all within the one day. Unfortunately, there was already a press release at the Journal of American Medicine, and the media had already been alerted. And, the suspicious amongst us would suggest that maybe that was all pre-planned, because it certainly seemed to happen really quickly, when you're talking about research. So overnight, prescriptions in the States pretty much fell to 5%. And really since that day, both the general public and doctors have associated HRT, estrogen predominantly, with breast cancer. So they've become intertwined in our neurobiology and our thinking and the narrative around women's health. And so in simple terms, I think that one incident, that one day in medical research really has created this controversy. And, but then of course, a few years later, they reported that actually the data wasn't statistically significant. And then this year they've just done their 20-year follow-up of the findings. And to be fair, there actually is an increased risk of breast cancer with that combination of estrogen and medroxyprogesterone. And we now know that these synthetic progestins do carry a small risk of breast cancer. What they did not publicise in May this year when they did their follow-up findings was that the women that stayed on estrogen on its own had actually a reduced risk of breast cancer by about 23%. So it's so much more nuanced, it's much more positive. And interestingly, it's still the estrogen that is demonized, but actually it was this synthetic progestin that was the problem. So nobody really likes good news. That's just how humans are wired, because we're designed to sort of stay away from the dangerous stuff, and that's how we stay alive. But unfortunately, because of that wiring, it has created an unnecessary fear that has really permeated all of the medical research into hormones. You get lots of really brilliant research that shows that there's great things that hormones do, but they often in their conclusion go, but there was that study that showed it caused breast cancer. And so it's almost like they just lost their marbles as they got to the conclusion of their study. So yeah, and that's a long-winded way of saying that's pretty much why the controversy. One really bad day in medical research. It's taken 20 years to undo. Yeah.
And it's interesting because we know now that estrogen is an anti-inflammatory, and we also know that since hormone therapy is kind of dropped, then the incidence of breast cancer has actually gone up. So it's kind of like all these other things that we're just ignoring, even though maybe they're the red flags we should be highlighting and noticing rather than this one study.
Yeah, and I mean, and this is in no way diminishing, the seriousness or the distress and the possible really serious outcomes that having breast cancer can cause women. And unfortunately, that often seems to be what happens. Is it's kind of a breast cancer versus HRT debate, which they're two very, very separate entities. Women get breast cancer, men very rarely get it. The increase of breast cancer goes up as you get older, decade on decade. It starts to increase in your 40s when your natural levels of estradiol, which is your ovarian estrogen, the anti-inflammatory one, starts to decrease. We know that in pregnancy, if women have a breast cancer, their breast cancer can actually regress as a result of their very high levels of ovarian estrogen and placental estrogen, estradiol and estriol and estetrol. So there's a lot more nuance in this conversation, and like so many things, it's really, you can't make it black and white. There's so much grey. So breast cancer is more common, and it's, we know that certain things are definite carcinogens for all sorts of cancer. We know that carrying extra visceral fat, drinking too much alcohol, smoking, but and a lot of that means the individual feels at fault, but there's a lot of things in our environment that we have just no idea about. We know that microplastics interfere with our genetic code. We know that air pollution, probably even climate change, potentially all of those things are disrupting our internal hormonal milieu, because, we're just all part of this massive ecosystem. And it's not one thing, it's a lot of things, which is so obvious when you say it, really, isn't it?
Yeah, and we do try and simplify things, don't we? It's just like, we're just one entity.
Fine.
Well, actually, there's so much going on in this one entity.
Yeah, and we're one ecosystem, but we're part of this, universal ecosystem, and everything is interacting. So it's complicated and nuanced, but it is really unfortunate because we've really had 20 years of women who've been denied hormone therapy where a lot of women could have benefited.
Yeah. And so what do you see are the key benefits for women when they do have that opportunity to go on hormone therapy, depending on what their situation is?
Yeah, so I suppose what the big things are that women often just say that they've got themselves back. And I think that's probably the most beautiful thing that you can hear. And you don't really get that with anything else in medicine, so since I've really started practicing what I would say hormone-focused medicine, has just been considering in women's mental health, and to be fair, in male health as well, thinking about their sex hormones, is that when you do a trial of hormones, it's not that they turn into somebody else, it's just that they go back to themselves of previous, when they weren't worried all the time, or when they could sleep, and just getting their self-esteem and their confidence back. And that's biological, and that's because these hormones are very potent neurotransmitters. So there's lots of reasons why that happens, biologically, not psychology. Psychology is as a result of what's going on in your brain, so that's the best thing. Hormone therapy can treat a multitude of symptoms. It's bizarre, the things that go away. There's the typical ones are the hot flushes and night sweats. But the thing that really bothers most women is that anxiety or overwhelm or loss of joy. That's really what changes somebody's sort of ability to function well. It's often not the hot flushes and night sweats, although for some women they are very serious. And it's things like not having the, verbal fluency, so not being able to find words, which is a big deal if you're a teacher or you're a CEO, not to be able to get your point of view across. And I always say, like, women weren't born with the bullshit gene, so we need to know we have to be able to speak. You have to be able to find our words because we don't like making it up. So it's a double whammy, that we're already struggling with the female lower self-esteem, and then our words disappear out the window. So that's why we see a lot of women, potentially at the top of their careers suddenly exiting the workforce, and I see that all the time in practice. There's argument whether that's true, but that's what I see in clinical practice, is women are starting to cut back their hours or leaving the workforce, and then they start on hormones and they're back to their old selves and they're fine. They're juggling the teenage kids, the elderly parents, the hard job, but obviously it's not just hormones. So so that's quality of life and symptoms. You can be phenomenal, but you do also, HRT's got really good data for bone density. So we know that it improves bone density, and that's been studied right up to the age of 80. So a low dose estrogen gel or patch can actually have quite phenomenal improvements on the bone very safely. We see there is a reasonable amount of data that shows that if you start hormone therapy within 10 years of your last menstrual period, you have a reduced risk of cardiovascular disease. There's some mixed data about protection from neurodegenerative disease. There's certainly some signals that it does reduce future sort of degenerative diseases of the brain, such as dementia or Parkinson's disease. So but it's not recommended for prevention of cardiovascular disease, which I find bizarre. I don't think the data is strong enough to recommend it for prevention of dementia yet, but I suspect that might change over the next 10 or 20 years. But it is recommended for low bone density.
And you mentioned before a couple of different types of estrogen. What are the different ones, and how are they different in terms of the impact they have for us?
So our dominant estrogen up until the point of menopause is our ovarian estrogen, which is estradiol, and that's actually made from testosterone. So testosterone is our most biologically present in the greatest amounts the whole way through our lives. It's just up until the point of menopause our ovaries convert it into estradiol. So estradiol is that lovely anti-inflammatory estrogen that also will build stuff. It builds bone, it builds muscle, it builds brain tissue, it builds myelin, which coats your nerves. As you start to go into perimenopause, you'll start to produce a bit more estrone, and then that is made more from the adrenal glands and in the fat cells. It is made a little bit in the ovaries as well. So that becomes the more dominant estrogen after menopause. There's two other estrogens. There's the one that's made by the placenta in pregnancy, and then there's one made by the fetus in utero. So those put there. And we actually do have a contraceptive pill that uses the fetal estrogen, which gives, I have to say, if you say that, people get the heebie-jeebies about that. And it's not made. It's just chemically identical. It's not that any babies were harmed in the making of it, but it does sound a wee bit Dracula-like. But yeah, so we have 4 types of estrogen, and then we've got 3 types of estrogen receptors. So we've got alpha, beta, and GPER. So there's a whole dance going on, between. There's not just one thing, and then, but with each of those, the more you look into it, it's so complicated. There's multiple pathways that estrogen is having. But the estrogen that we use in HRT is the body identical estrogen, is chemically identical to that estradiol. It comes as a gel or a patch or a tablet. You can get it as a spray in the UK and maybe in the US, but gel or patch, and they're equally as effective, they're the same. Different women absorb patches better than another women absorb gel better. I don't tend to use tablets so much because they can activate clotting factors. Still very low risk, but they can have that increased risk of thrombosis, like a DVT, a leg clot or a lung clot. So that's the estrogen. We've got body identical. We've loads of gel in the country. The gel seems to be available in abundant supply. The patches, as everybody knows, can require multiple trips to multiple pharmacies, and that has been a real problem because the patch is a great option for lots of women, but the supply chain's not going to be fixed anytime soon.
Yeah, and I know, because for me, I find the gel isn't as effective, but yeah, otherwise I'm spending lots of time visiting different pharmacies in town and just go, have you got any of these? And they're like, I'm sorry.
I know, it's crazy. People, I think lots of my patients have felt like, they're drug addicts trying to find their patches or going off to areas where there's clearly low prescribing, and then they feel a bit guilty that they're stealing it from these areas of need. But it's crazy, yeah. But the patches are made. Yeah, again, it feeds into my conspiracy theory. The patches are made by big companies, and if you make a whole pile of drugs, and most drugs treat chronic disease, you wouldn't really prioritize the drug that's going to reduce the need for all of your other drugs, would you? That doesn't make any profit sense. You're not going to make the expensive drug, because HRT is expensive. Natural hormones are expensive to make, so you're not going to make the drug that has a very low profit. That'll knock all of your other drugs out of the park. I wouldn't do that if I had a big pharmaceutical company.
Yeah, your shareholders probably wouldn't appreciate it. So another area of interest for you in terms of the hormone area is the PMDD, or premenstrual dysphoric disorder. So tell us a bit about that, and why is it important that we actually start understanding that a bit more?
So as my interest in perimenopause and menopause developed, I started to think more about the impact of sex hormones, which shouldn't really be called sex hormones because men and women have the same hormones, but how these hormones impact your brain. And obviously our brain is what determines our mood and our behavior. So that was, it's so stupid now when I realize how obvious it is, but it's one of the greatest changes for my practice. So looking at just understanding the menstrual cycle, the changes of estrogen and progesterone throughout a normal menstrual cycle for some people can have really quite significant effects on their mood in the 1 to 2 weeks before they start having a period. And in that 1 to 2 weeks, you're getting quite a lot of change in both progesterone and estradiol. Testosterone stays pretty steady across our menstrual cycle. So estimates are around about 5% of women have really quite severe mood changes in that 1 to 2 weeks. For some people, it might be a couple of days, but for some people, it might be 2 weeks. But almost up to 20%, up to about 20% of women probably have quite significant premenstrual symptoms that don't quite meet the diagnostic criteria of PMDD, but actually are probably not close, where they really do get very depressed or very anxious. Other symptoms would be eating, sort of overeating or undereating, oversleeping, undersleeping. Some women get very impulsive and do things they wouldn't normally do. It can, increase your risk of drinking too much or, making bad decisions. And for a small group of women, they do get monthly suicidal thinking, which is really horrific. And a tiny percentage of those women will actually have a monthly psychotic episode. So I do see I see quite a lot of younger women who are pretty close to meeting that diagnostic criteria. And it's really, it's quite scary for them, to go into that awful mood every month. And I wonder if it is actually becoming more common, because I certainly see quite a lot of it just in my normal general practice population. So that also can be treated with either body identical hormones or the contraceptive pills that contain natural estrogen can be very effective, because these are often younger women who often have a contraceptive need. It does seem to have a bit of an overlap with neurodiversity. So there's a thinking that perhaps a certain group of women who get PMDD are probably also have ADHD or ADD or maybe autism ADD. So they're particularly sensitive to change, and there's no bigger change than your hormones changing in your brain. And there's also a bit of an overlap with hypermobility. So certainly often ask these younger women or, older teenagers, did you ever do gymnastics or ballet? And they like, yes, they've all been hypermobile. So there's definitely a genetic underpinning to a subgroup of those women. And they often get heavy periods as well. So these are, girls in their late teens who are dealing with, monthly really difficult moods, heavy periods, perhaps chronic fatigue and POTS, which is a problem with balancing your heart rate and your blood pressure. So they're often dealing with all of these things. And then somebody said, actually, I think you've got ADD as well, and it's year 11, and the HSC is coming up if they're in New South Wales. So So it's really interesting, just, and even for some people, just understand why, that's not, they're not, and the same with perimenopause and menopause, to understand why you're experiencing symptoms is so validating. And for a lot of people, that's actually enough. They don't necessarily need treatment. It's just to understand why and, to maybe plan their life around it a bit. But just and then for a lot of people, they obviously want to get rid of those awful feelings, and then they've got options for treatment when you understand what it is. And it's always part of a whole holistic package of looking at, your nutrition and your exercise and your sleep and your social connection. But often getting the hormones on board allow you to make better decisions in those areas as well. So yeah, so PMDD is I think a lot more common than we appreciate, and really it's a really serious mental health issue for women.
And I wonder if that, it's similar to like, all the other things that we go through where we just kind of assume it's normal because we get a period and a period is what you go through. We're used to sort of thinking, oh, it's just that part of having a period is that it's going to be like this because this is what's normal for me.
Yeah, absolutely. That's one of, I have to try and say, it's not normal to lock yourself in your room for 2 days in the same way as that, like 70% of women with heavy periods just suck it up. It's not normal to not be able to go to school 1 to 2 days every month. It's not normal for your pain to be so bad that you can't socialize with your friends. And it's the same with premenstrual mood changes, and the same with perimenopause when heavy bleeding, so that kind of those teenage years where hormone fluctuations are often worse are very similar to perimenopause. There's a lot of sort of neurobiology, similar stuff going on in the brain. But really explaining to people that it's not normal, and you don't have to suck up that level of, of strife and, difficult symptoms. So that in itself, again, is really, really important, just creating that awareness.
Yeah. No, and, it's such a big thing to not think that it's just you, that other people are going through it. You're not going crazy. It is something that is happening, and that's it's valid. What you're going through is valid. Yeah.
Yeah, no, I think just understanding that this is like how you feel and how you behave is a result of what's happening in your brain, and your brain is an organ like your heart or like your leg. It's really hard to have the perspective on it because you can't see it. You can't think about your thinking. You can't sort of split like that. But I think a lot of people, it is really reassuring to know that this is why they're experiencing these symptoms, and also that they can do something about it. But it's not because they're a failure.
Yeah. And so coming back to the menopause side of things, what was your experience, or what is your experience going through that transition?
I think, people ask me this and I feel like I've cheated. So I really didn't. My experience has been more of a professional one. And, it was a patient that asked me to go and upskill because I didn't know how to prescribe testosterone. And that really was the start of my learning journey. And I suppose in retrospect, I probably was a bit more irritable before my period, but not at a level that was significant. But I'd certainly started to get some injuries. I'm quite a keen but rubbish soccer player. So I'd noticed that I was, not recovering from injury so well. And actually my 2 main symptoms were itchy ears and an itchy back, which completely disappeared on HRT. But the thing that has really changed is my verbal fluency. So I can sound like this that on this podcast, but the ability to string long sentences together and find words is very different than how it would have been, even 5 or 10 years ago. And I think that's probably the most exciting thing for me. So I was very lucky. I don't have a history of PMDD. I don't have a history of postnatal depression, and I'm not neurodivergent. So I do think all of those things tend to put women at higher risk of having tougher time. And certainly women who've experienced complex trauma or live with domestic violence or in difficult relationships, certainly we know that they tend to have a much harder time in perimenopause. So I think I'm very, very lucky that I didn't have any of those things counting against me. So my experience was certainly a bit easy. So I do feel I've dodged a bullet on that one. I feel a bit of a cheat, but I'll take that win.
Oh yeah, I'd make the most of it. I'm sure there's other areas.
I'm sure there's
not winning.
I'm sure there's bad stuff. There's other bad stuff ahead. Yes, absolutely. I'm sure I'll get slung something from another angle.
So the other thing I wanted to ask you, and like I'm struggling with my own brain fog a bit at the moment, so if it doesn't make sense, I'll start again. But with the whole, the symptoms and we don't know who's going to get it bad and we don't know who's going to get it good. Is there any correlation that we're aware of yet between like having children later in life and things like that, where it's a big hormonal fluctuation later that might trigger off an early perimenopause?
Not that I've seen. That doesn't mean it's not true, but not that I've seen. The things that do certainly would predict a worse experience of mood symptoms in perimenopause would be women with a history of severe PMS or PMDD, women with a history of peri or postnatal depression, women with a history of, which I haven't mentioned, of difficulty using hormonal contraception, which again can often really play havoc with your brain neurotransmitters, women who have a history of complex trauma as a child, women living with domestic violence or who've experienced, and I'm sure a lot of the people who've living through war zones are having a worse experience as well, and women who are neurodivergent. So those would definitely be predictors of more severe mood symptoms, and then genetics as well. So, often if somebody has a family history of having had a significant, of their mum or perhaps their paternal granny having had a difficult perimenopause, granny was admitted to, a mental hospital at 52, or, that kind of, family history of suicide would always make you really, concerned that somebody might have it. But we're only part of what we experience. It's only a small part of what genetics are. Only a small part of what determines how we experience things. A lot of it is environmental, and I think so important for younger women, when they hit 35, to really be aggressively looking after things that do make a difference, like your nutrition and building muscle, and prioritizing sleep, as much as you can if you've got small children, but watching your alcohol intake. These things are so important, and really there's not no point in taking hormones, but really those things are so important alongside. So, but yeah, no, I'm not aware of anything, even with IVF, predicting a worse experience of perimenopause. I would say, obviously, if you have your children later, it's not uncommon to go, from breastfeeding into perimenopause.
Yeah.
And you haven't a clue what's going on.
Yeah, I had no idea. And I guess that's why I'm asking, because when I'm talking to women that I know, we're all a similar age, and a lot of us have children at a similar age as well. I know my sister's kind of getting nothing. She's like, I'm fine. My mum didn't have anything. And my maternal grandmother, she actually had a hysterectomy when my mum was only about 4 because she had the heavy bleeding that wouldn't stop. So, and she went on hormone therapy back then and it didn't stop her. Like, she lived through to her 70s, no problem. It is interesting as to why different ones are different, when you sort of think there's got to be some way of, surely there must be some way that we can work out what we're expecting. But as you say, there's so many different factors. I think even if you had identical twins, they probably wouldn't have the same.
Yeah, and I'm actually not sure. I'd have to go and look at the twin data. I do know that in the identical twin data that they do better. You see that they do better on hormones, long-term health benefits. I do know that from twin studies. Cool. But in terms of predicting who's going to have, I would say the things I've said are big. They are actually the big predictors, and to be honest, they're quite marked. And, things like living with family violence is very common. It's also a time a lot of women get their ADD diagnosis. A lot of my patients get a bit offended because I ask that all the time. I'm like, you might have undiagnosed ADD. And then they go, do you think you have undiagnosed ADD? Maybe. I had a patient yesterday who told me I had to go home and do my own score. And maybe she's right. But, so certainly, that would be certainly the women who have, most women have been missed in terms of neurodiversity by the time they hit 30, by the time they hit 40, they've not been diagnosed. They're just starting to get their kids diagnosed and then going. And I do think that because estradiol is so important in the dopamine system, once those levels start to go down, then the wheels can often come off in the early 40s, definitely.
Yeah. Now, the other one I'm really keen to ask you about is alcohol. So my understanding, and I could be totally wrong here, is that because our body's trying to process alcohol, they're not able to deal with our hormones as well. Is that how it works? Is that the challenge with it?
Oh, you're going to challenge my liver physiology. So yeah, so well, different things. Alcohol is a depressant, so it works on it works as a neurotransmitter in the brain, so it causes a direct depressed effect, and it works on the GABA system, which is where progesterone works, and so it'll be competing with progesterone there. So you'll get that kind of depressed state, and then you'll get a rebound in agitation, which is the hangover the next day. So there's a direct mood effect from alcohol, and that's probably a big part. And yes, the other thing is when your body's when your liver's trying to process alcohol, it's not so much that it can't process the hormones, it can't process anything else. So you get these massive, glucose shifts, and your liver doesn't like that. It wants to get things in a nice steady sort of drip supply. It doesn't like getting a big load of glucose at once. It gets overwhelmed, which is why it starts to deposit it as fat within the liver tissue, and you get this fatty liver, which can be caused by alcohol. It can also be caused by processed food. So it's really that, yes, the liver doesn't like to deal with a big dose of carcinogen at any one time. Dose of glucose, again, because then it becomes a problem. But it's also the direct brain effect. It's not, and I think there's other things, that alcohol will interplay with your insulin. It's not good for muscle strength either. So there's lots of sort of bits and pieces, and it has a direct effect on your heart as well. So on your heart rhythm. So it has effects everywhere.
So it almost sounds like estrogen does the good stuff and alcohol does the opposite stuff.
Pretty much, yeah.
Yeah.
Definitely. But I mean, and I would say that, because estrogen gets all the kudos, so she's the eldest child, and then progesterone is sort of like the middle kid. So progesterone, I always feel, doesn't get enough attention, and largely has been regarded as only important for women who have a uterus to keep the lining of the uterus thin if they're on estrogen. But actually, it's got some really good data in bone density. It works as a neurotransmitter. It's wonderful for sleep and anxiety in a lot of women, although not all. Some women hate it. It also builds the myelin around the nerve cells. And then we've got the sort of the third bonus baby who appeared on, just recently, and that's testosterone. So that's I always picture testosterone like the wee bouncing sort of blonde haired toddler bounces on the scene, like, whoa, look at me. So progesterone didn't get a look in, and then testosterone's come in and got all the attention now. So all three of those hormones are really important. But it's only progesterone and estradiol that plummet at menopause. Testosterone should not, although for a lot of women it does gradually decrease, and for some women it also seems to plummet for various reasons, including autoimmune disease. So it's all three of those hormones are doing all of this and balancing, really doing the absolute opposite to alcohol.
I love that, and I love the way you described it, because in the Queen Bee resources I've actually got them as, let's meet estrogen. Let's meet progesterone. Let's meet testosterone. It's like kind of like these people, and so I love that you've done that. I'm going to go and check what their bios are and make sure that they're up to date.
I know. I feel bad that I've made testosterone like a male toddler. That's probably deeply entrenched internal misogyny on my part.
Oh, I've got her as a mysterious woman who just looks really exotic. So there you go.
Yeah.
So talking about hormones, let's talk about your new project, Healthy Hormones. What's it all about?
So earlier at the start of this year, there was a group of us. We have a small WhatsApp group, and so we're working around Australia doing very much a lot of perimenopause, menopause, PMDD, and a bit of perinatal mood work. And we found it so supportive to be able to ask the sort of difficult questions, unusual questions, for patients that weren't fitting into the guidelines, because the guidelines are very limited. They don't really allow that flexibility for the range of presentations that you get. So that was really useful. And so we started to think that really what we needed was to be able to educate more or support more doctors on this journey, and let them be able to ask the questions that we were able to ask each other. I'm laughing at the interference, sorry. And so that we started to build some content. So what we've got at the minute is we've got a medical community that has, I think, about 800 members now. So mostly GPs, some specialists, and a lot of allied health professionals. And they can come on and ask a question, and, other people can answer. We quite often put in our tuppence worth. We don't always agree. I mean, it's a very grey area of medicine. And we're also trying to share useful resources, useful papers, different podcasts, and really expanding that network of doctors around, particularly doctors, but also allied health professionals, including psychologists as well, to really, so that women can get the treatment that's right for them. Because at the minute we've got a growing awareness in the general public, but we don't necessarily have matched awareness or education of medical professionals. And you read about that all the time in the paper, that women are going along to the doctor and they're being dismissed, or they're being offered X, Y, or Z, and that isn't what they wanted. So really it was to try and address that need that, I can't take any more patients. The other people in the group were all full, but we really wanted to do something for, the whole of Australia. And it's a model similar to Louise Newson. She's kind of the champion of this globally. She set up an education platform and website and, community several years ago, which was a great support to me. But we wanted to do something that was Australia specific, so that it would apply particularly to the issues that we have. And we've just launched our public facing site as well, so women can come on and get some information, and then we're building a forum for them that they'll be able to come in and ask questions. It won't be medically moderated, because our medical defence companies don't like us doing that. That's kind of danger zone. So it will be more of a community support group rather than medically moderated. But yeah, so it's really building. So it's great. And it's lovely meeting lots of wonderful people in this space. And, there's so much we all need to learn. So it's wonderful. Huge amount of work. It's the second job in the evening.
Yeah. And that's it, isn't it? We're almost like going back and doing all the, the re-education for either women or for the medical professionals, and going back to where they started and saying, hey, you actually missed this, not just a chapter, but an entire book on women that you need to read to be doing things the right way. Let's get you catching up, but you've still got to create all those resources as well and update them as research comes in. And yeah, I know I love seeing the updates that come through Healthy Hormones.
Yeah, no, so it's really, because it's so much more than perimenopause and menopause. It's the whole of women's health that we've never looked at through a female lens. Sex as a biological variable of disease. Heart attacks present differently in women, strokes present differently in women. Women, have an increased risk of, osteoporosis. They get different diseases. We also get the same as men, but all of our medical model has been built around, as everybody says, a 70-kilo white male, of which there's very few. So there's been no accounting for sex, biological sex. There's been hardly any accounting for races or ethnicity, and then so really it's a very narrow model that needs a urgent review. That's just to think at least of sex being different, that women, have different things because of these hormones. So from puberty, we experience things differently. That's why women don't get diagnosed with ADHD, because they present differently. And, all been and we've been called hysterical. Everything has been a psychological issue, but actually it's because we experience things differently. So yeah, really, once it's like, it's an infinite piece of work. It's infinite. There's no end to what we could do on there, which is exciting, but overwhelming.
Yeah. Just got to take small bites. I mean, I find it fascinating that even like in, testing, they use, for women's health, they would still use male rats because the female rats were hormonal and it was complicating things.
Yeah, that only changed in 2016. So that's so recent, using female animals. And I mean, they've introduced human females into clinical trials from 1994, but the majority of drugs I prescribe as a GP were tried and tested before 94. So the majority of drugs that I use on a day-to-day basis, apart from HRT, that has been used, only trialed in women. But everything else has been tried, researched in men, not women.
Yeah. And I think that's the thing. You're constantly learning from how things are working for your patients. So being able to listen to them and adapt, because you're not able to get that information from other sources at times.
Yeah, absolutely. I think that's the value of being a general practitioner. You see people a lot and you see them repeatedly and you see them in their home environment, and you can learn so much from your patients. Definitely that's one of the biggest learning tools, is just listening and watching, so much.
Yeah, no, that sounds great. Well, that's all the questions I have. Is there anything else that you'd like to share while you've got the stage, so to speak?
No, I suppose my messages are always, that women tend to be quite in tune with their body, so I think as a female, somebody who's been born with ovaries and you're struggling with your mood, it is really worth trying to track, your cycle and your mood symptoms at any age to really, and I think younger people are much better at doing that, to really understand how the ovarian hormones impact everything from your brain to your heart to your gut. Everything is impacted, and, becoming in tune with that from a young age perhaps will allow women to be more aware of when they do go into perimenopause, and at least to have that understanding so that you don't get blindsided by it, and that, you can sort of avert any serious mental health issue, which unfortunately some women do. The second thing is that, it's not uncommon to go into perimenopause by the late 30s, and that a lot of the symptoms or start in the brain and cause mood symptoms well before your periods change. So a lot of women do present just with being a bit anxious and not being able to sleep. And unfortunately, still most of those women get put on an antidepressant first. So those are, and the third thing is that it's so important, to really look after your nutrition and your exercise. And it doesn't have to be a huge amount, but try and do something every day. I think that's so huge. Just try and eat, plenty of protein, plenty of fibre, i.e. just real food. Just try and move every day. I think those things will set you up well for future health.
Yeah, I think that's, as you say, a great reminder at any time of life, but particularly when you get to this stage and everything's coming home to roost.
Yeah, it's much easier if you start it when you're younger. It's harder.
Awesome. Well, thank you so much. Today we've been yarning with Dr. Ceri Cashel, a specialist GP based in Avalon on Sydney's northern beaches. Her focus is on hormones and their impact on our health. In particular, she focuses on women during perimenopause, premenstrual and perinatal stages, as well as we were hearing with PMDD. She frequently speaks at events and webinars and appears on podcasts and in the media to help raise awareness about hormonal health. Ceri is also co-founder of Healthy Hormones, the online menopause community we were talking about, which offers free learning and support for health professionals and all Australians. Thanks so much for joining us today, Ceri.
Thank you so much. Thank you.